Welcome, everybody. Before I introduce today's speaker, I'd like to take a moment to acknowledge the individuals who made this lecture series possible. Eleanor, or Ellie, Trowbridge was a member of the Berman Institute of Bioethics Board for whom palliative care was an issue of great importance. Ellie devoted much of her time at Johns Hopkins, both as an employee and as a volunteer. She served in the Johns Hopkins University Development Office and raised critical support for the Department of Oncology. She chaired the Johns Hopkins Bloomberg School of Public Health's Council on Population and Family Growth, and she served as a development consultant for the Children's Defense Fund and Population Action International. Indeed, in 2003, her tireless efforts on behalf of the university were recognized through receipt of the university's Heritage Award for Outstanding Service. Ellie's commitments took on a deeply personal significance with the death of her daughter, Sheila Huxler Reeves, who succumbed to breast cancer in 1988. Ellie served on the Berman Institute's board until her death in 2007. This semi-annual lecture series, which focuses on long-standing and emerging ethical issues in palliative care, would not be possible without Ellie's generosity and that of her families. We are here today to help realize Ellie's vision and that of this institution to advance palliative care systems and interactions for the benefit of all. In that spirit, I am pleased to introduce today's speaker, Dr. Robert Holloway. Dr. Holloway is a professor and chair of the Department of Neurology at the University of Rochester's School of Medicine and Dentistry. He received his undergraduate and medical degrees from the University of Connecticut and neurology and health services research training at the University of Rochester, where he has been on faculty since 1993. Dr. Holloway is boarded in both neurology and palliative medicine, and his research interests are broad, including experimental therapeutic and outcomes research, covering many areas of neurology. He has been the recipient of numerous awards, and he is the PI on several institutional grants that support clinical trial research and career development. So with that, I would like to introduce Dr. Holloway and thank all of you for being here.
Thank you so much, Mary. I hope you all can hear me, and I am absolutely delighted and honored to be here today. I will start by just sharing my screen. And can you all see my screen okay?
Yes.
Okay, great. I just want to say I'm so honored to be here and have some small part in trying to advance the field of palliative care, and in particular, my area of interest, neuropalliative care. And I just want to thank you all again, and the actual focus of this lecture to advance the field. I've just benefited so much by so many people across actually the globe, including actually many of the writings and the influences of members of the Berman Institute, including Dr. Kahn and Dr. Sugarman and others. So I'm honored to be here, in some ways a little intimidated, but I'm delighted to be part of a conversation today. I want to just give some credits and disclosures. I adapted the material information from the following Education in Palliative Care and End-of-Life Care Neurology, or the EPEC-N module. We just launched the International Neuropalliative Care Society and had our first annual meeting this past November, and we're planning our second annual meeting this coming November. And it's a growing dynamic field that really focuses on some of the unique aspects of the patients with neurologic illness and their families. I have, as was mentioned, institutional grants that fund several of my programs and research. I am boarded in neurology and hospice and palliative care medicine. I think that's influenced my thinking over the last many decades. And I am not, obviously not an ethicist per se, but I tend to agonize about the many issues that I confront with. And like I said, I've benefited by so many. I want to talk about something that probably is so central to person-centered care, but receives a lot, very little attention, and that's prognosis. And some of the, as you'll see, the ethical dimensions that arise in this area of prognosticating illness, and in particular neurologic injury. And these are just some quotes that I think sum up some of the sentiments of prognosis. The practice of medicine is like wine, and prognosis is the dregs from an unknown internist. And then patients and families will forgive you for a wrong diagnosis, but will rarely forgive you for a wrong prognosis from an internist in the Pacific Northwest. I have had my share of prognostic mishaps, and I will say they probably are the most memorable and some of the most post-traumatic experiences I've had in medicine. One I'll never forget, and actually I wrote about it as a self-reflection, was a patient who I removed with ALS, who I removed the ventilator from in their home. It was a 32-year-old gentleman who was surrounded by his family, 7 individuals, his parents, his wife, and 3 of his friends that he wanted to be there. And as part of the process of me trying to orchestrate that withdrawal, I prognosticated to the family that I thought it would take about 10 to 15 minutes for him to actually die after the withdrawal of the ventilator. And 44 minutes later, after a harrowing 44 minutes, I pronounced him dead. And it was a long, very misprognostication on my part. And I've thought a lot about the emotional, spiritual, ethical, and moral dimensions of that. And I wrote that up, and I'll say a little bit more about that later on. I've had several others, and I know many physicians and providers actually share in their prognostic mishaps. And so I think it's always influenced my decisions, but it has received less attention in the literature. Many of you may know Nicholas Christakis, who's a social anthropologist from Yale. And actually, he's a hospice physician who turned more social anthropology and has written some wonderful books. This book was written in 1999, Death Foretold. And it was 1999, but very little has been written about prognosis in the literature. And Phil Tetlock, many of you may have read this book, Tetlock and Dan Gardner, Superforecasting. And I've actually adapted some of my thinking to address some prognosis issues in medicine and neurology by actually utilizing some of the frameworks of superforecasting, the art and science of prediction. Phil Tetlock started a superforecasting tournament where he would actually invite individuals from the public to actually compete with intelligence analysts from the IARPA, or the think tank for the intelligence agency. And he would actually have competitions about who would do well in forecasting and what are the characteristics of good forecasters compared to actually intelligence analysts who had access to information, secret classified information, and what he found was that there was a group of individuals who actually could outperform the intelligence analysts in their super forecasting. And they were not even experts in the field, but they had a series of characteristics that allowed them to be what he called super forecasters. And what are those techniques, and how well are we doing compared to some of those techniques in medicine? And this just happens to be one of the super forecasters. He is a retired hydrologist, Bill Flack from Nebraska, and he consistently outperforms the intelligence analysts in the context of his predictions. And these predictions are usually kind of geopolitical predictions, months or years out, and compared to actually others. So what are the characteristics that Bill Flack and other super forecasters have, and how well do they outperform? And are there characteristics that we as physicians or providers can adapt to be better forecasters? And how does that apply to even medicine in general? So these are the learning objectives: to understand the importance and barriers of prognosticating in clinical practice, to reinforce skills to become a master prognostician, developing radical awareness for common biases that may interfere with your prognostic communications, and to understand and manage prognostic discordance when it occurs with patients and families. And I'll go through each of these learning objectives, and at the end of each section, I've just put out a few kind of questions that I have that kind of overlap and have some ethical dimensions to them that, as I said, many of them I've struggled with for 30 years to kind of unravel and think through. And some of them are kind of more recent based on work that I've done with some of the collaborators that I have. I do want to call out the EPEC-Neurology series. There's 26 modules that are currently available. If you just put in EPEC-Neurology, actually these have slides. They have kind of written material to guide for education, and it's a real effort to start teaching neuropalliative care more broadly. And we're going to be having, as part of our International Neuropalliative Care Society, a Teach the Teacher conference for those who are interested in actually becoming teachers to share this material more broadly in your institutions. And as you can see, we have several that cover ethical dimensions and communication, as well as kind of neurology specific modules. I also want to call your attention to this. Many of you probably have seen this, but it's the Lancet Commission on the Value of Death, Bringing Death Back to Life, which is a polemic on kind of death systems and dying, and kind of a current commentary on the state of it across the globe in high, middle, and low income countries, and really challenges us to reimagine death and dying to achieve kind of that realistic utopia, including conversations about death, dying, and grief becoming more common. And actually prognosis and the concept of sharing prognosis figures very prominently within this report. And actually, if you do a search of the word prognosis, it comes up over 10 times in various parts of the commission that emphasizes the need to be more honest about the roadmap and our future possibles with patients and families and ourselves. And how do we have that fight that cognitive dissonance that often exists around thinking about the futures that are unknown and often scary. And to that end, I firmly believe that everyone deserves a palliative care approach, providing a diagnosis, skill, and compassion, addressing emotional and spiritual concerns, and providing anticipatory guidance and advanced care planning, which really does center on the future. And how do we provide such a roadmap to patients, families, and ourselves for what often feels like a dark, damp, cold cave, and shine some light in ways that can help us navigate and be kind of Sherpas to those patients we are privileged to take care of. Also address non-motor symptoms and support the family. And even Hippocrates, way back when, knew that prognosis was central, and this was a quote, it seems to be highly desirable that a physician should pay much attention to prognosis. If he is able to tell his patients when he visits them not only about their past and present symptoms, but also to tell them what is going to happen, as well as to fill in the details they have omitted, he will increase his or her reputation as a medical practitioner, and people will have no qualms in putting themselves under their care. So I don't really have to go through, we all kind of have an intuitive sense of what prognostication is, estimating and communicating what to expect for an individual's disease course. And as Cambridge Dictionary said, the act of making a judgment about what is likely to happen in the future. Specifically about neurologic diseases, obviously neurologic disease is different than many other illnesses just because it centers on the self so much. And unlike cancer, which often doesn't involve the brain directly, can indirectly, neurologic disease often really does fundamentally change kind of our health states and our persons as we are. And many of the health states may be considered worse than death. And I'll review some of the literature on that. This is actually Elise Everett, who is now a palliative care physician in St. Louis, who actually surveyed about 200 stroke patients who were admitted. And she just asked a simple question about what those patients who were admitted, as they thought about their futures in various health states, and how did they rank them as worse than death to much better than death. And you can see in teal hair, the percentage of patients who were admitted on a stroke service, many of whom did not have these actual disabilities, but who in their population viewed their health states worse than death. And you can see it's substantial. And many of these are as a consequence of the functional and cognitive impacts of neurologic illness. So these patients are grappling with their future selves. And as we increasingly have futures with increasing, I suspect, disability, We have to be thinking about how to handle those future selves when we do advanced care planning and negotiating goals of care. Prognosis is highly complex in its prognostic predictions, not just in those physical dimensions that I mentioned, but actually how well do we predict how well we will feel? And actually we have to do both of those exercises in terms of trying to prognosticate for patients and families. The easier thing sometimes we think of as mortality and physical, but actually how well we feel is also a highly complex prognostic depiction of the future that has implications for goals of care's discussion in family. It's also rife with uncertainty. It is impossible to lay down binding rules because two cases will never be exactly the same, as was said by Helmuth von Moltke, the chief of the Prussian army, and who is considered the father of the modern military methods of armies in the field. We're often dependent on surrogate decision-making, and it's central to shared decision-making, many leading to life-death decisions. You know, and I focus on, in much of this talk and some of my thinking, all around these life-death decisions with usually sudden acute brain injury, but it can be in any severe neurologic, where we actually undergo the shared decision-making process. You all know this. This is one rendition of it, the MVP framework written here by Rob Horowitz, the chief of our palliative care service, medical situation, values, and plan that actually leads to so many decisions in discussions with patients and families. And I just put the question in there, informed consent. And you'll get why I say that, because I actually think some of the time when we actually make these life-death decisions, I always think about the adequacy of informed consent and contrasts some of the medical procedures we do and the things we go through to document informed consent, and how that contrasts with some of these real huge decisions and what do we actually do document in the chart after discussions with our patients and families. And we've done some research on that. I've been worrying about this ever since I started taking care of stroke patients 30 years ago. Consequences of the errors. I just would agonize about being overly optimistic in my prognosis and how that could lead to overuse of life-sustaining treatments, shown here in blue. I also would agonize about being overly pessimistic and how that may influence in kind of a self-fulfilling prophecy, which I'll talk to a little bit later, and underusing life-sustaining treatments. And actually, what are the consequences of error on both sides of those questions? And then if you look at actually what and how our end-of-life care practices across the United States and the globe, we know there's a huge amount of variation in the way end-of-life care is practiced. And this is one of a series of studies that myself and colleagues have done over the years, looking at variations in practices in this case, stroke patients receiving a feeding tube. And all this study looked at was the prevalence of going into the hospital with a diagnosis of stroke and coming out with a feeding tube, and actually studying the variation in that procedure. And we've done this for intracerebral hemorrhage, ICH, ischemic stroke, as well as for comfort measures only, and as well as for withdrawal of ventilation in patients who are admitted with ischemic stroke. And the results are all the same. There's a huge amount of variation in these end-of-life care practices, all the way from 1% of patients admitted to a hospital to up to 30, 40, 50, 60% of patients. That's not explained by just patient preferences, but other factors. And we talk about surgical signatures as well as, but we don't often talk about end-of-life signatures. This is often referred to as the hidden curriculum. If you look at a Dartmouth atlas of variations in practice on where and how you'll practice medicine by how they practice end-of-life care practices. And this is definitely occurring in stroke practices across the United States and many other end-of-life care practices. And so I do worry about this and kind of the state of the adequacy of the informed consent process, about how well prognosis is being delivered, how well are preferences being ascertained. When I'm on the stroke service, I often will say to actually residents and the students that actually diagnosing stroke is the easy part. Actually, it's diagnosing preferences and communicating prognosis. That's the hard part. And that kind of messy muddle is, I think, rife with, like I said, uncertainty. We kind of muddle our way through it. But I do think it leads to potential errors on both overuse and underuse. And I've always been troubled by that. I think I've been very troubled by that. And how can we actually address this problem? So in this first section, I have, why do we tolerate different standards of informed consent with less rigor required for decisions with life and death implications? I didn't mention, but I wanted to, that we also studied how often preferences and values are documented in a cohort of stroke patients who have died in 30 days. And actually 40% of the chart had no documentation of values and preferences. And the rigor of our informed consent process is just, I think, remains to be questioned in terms of some of the end of life care practices. What do we require as opposed to doing an LP, for example? The other ethical question is, how much variation in end-of-life clinical practice should we tolerate, knowing that errors occur in both directions, leading to prolonged suffering and premature deaths? And I'll hold these off to the end. And I thought maybe some of these questions would be part of the conversation I have with the fellows at the end of the discussion. So I have about 8 or 10 of questions that we can discuss. And so how about reinforced skills to become a master prognostician? And one of my favorites, I was a double major in college, and English and poetry was my double major. And John Keats, the physician poet, is one of my favorites. And he said, at once it struck me what quality went to form a man of achievement, when a man is capable of being in uncertainties, mysteries, doubts, without any irritable reach after facts or fiction. And I emphasize here that to be a good prognosticator in medicine, you have to be both a good superforecaster and a supercommunicator. And the skills are different for each. And the biases are different for each. The more I think about it, the more complex it gets. And I'm just thrilled to be talking with people who kind of cover so many dimensions of scholarship to think through this issue, because that's what it's going to require. And I will first start off by thinking about super forecasting. What is it about Bill Flack that made him such a good super forecaster? And is it the same thing as being a super communicator? And so becoming a super forecaster, this is kind of what I wrote about 2014, published in Neurology, around kind of anticipating, anchor, tailoring, and debiasing. It's a very similar framework actually to Phil Tetlock's work. And I will go through each of these briefly so you can get a sense of what are the things. Then I'll summarize what are the characteristics that made Bill Flack a super forecaster. So anticipate with an active, open mind. What information will the patient and family want? Do your homework, obvious stuff. Super forecaster, break problem into smaller questions, and then think through 2 simple questions: how long and how well, kind of if they're relevant. Both are. And then how well is actually thinking about physical and emotional. The one thing that actually Phil Tetlock in his book emphasizes is kind of starting with the outside view, or anchoring your prognostic estimate on something outside of the patient in front of you. Go to what he calls the comparison class, and start there. I think you should start with, even this is just prognostic awareness, start with survival curve and typical disease trajectories to start getting familiar with prognosis more commonly or more frequently. And then again, start with that comparison class. And then for these, you can use prognostic indices, web-based tools. You can use these as starting points. They're not designed for individual decision-making, but then you start there and then you individualize. So for example, I actually carry this, I used to carry around Snellen cards, eye charts in my pocket. I actually carry around this in my pocket now. This is a life expectancy table. And it's just, I pull it out. I literally 2 weeks ago on Tuesday, I saw with our stroke team, 100-year-old woman who actually had a thumb stroke. It was fascinating. It was literally at the homunculus, tiny little stroke that caused her thumb to be weak. But she was there. She was a beautiful 100-year-old woman. And as we were talking about the case outside, I just asked the team, what do you think her prognosis is? We often don't think about that. Just what is a 100-year-old prognosis, non-Hispanic, white? And I had everyone guess. They all guessed a little bit less than what this life table shows. And I suspect hers is around there. And so it's 2.2. And I just asked them again. I said, what do you think life expectancy of a 100-year-old non-Hispanic Black woman would be? And actually their estimates were about half of what they chose for the white female. And then I said, well, it's actually 2.7. I said, and we just had a little discussion about why that may be the case. And it probably challenged many of their assumptions that they had to think about that external class and just start thinking about prognosis in a different way. I don't have all the answers, but it's just cultivating this prognostic awareness. And then we have these kind of curves, trajectories. We think about growth curves at the beginning of life. Rarely do we think about trajectories at the end of life and what path patients make, that roadmap, broad strokes, but starts getting us thinking about it. The short period of evident decline, the prolonged dwindling associated with dementia and Parkinson's, the chronic illness with exacerbations. In neurology, multiple sclerosis is one, COPD in medicine is another. And then what, Claire Kreutzfeld, a longstanding colleague in Seattle, and I wrote a couple of years ago, the severe acute brain injury trajectory, which has its own challenges, but start thinking about it in that way. And then using prognostic indices or tools, again, as a comparison class to start your thinking. There was one example that was written on using the comparison class or starting with the inside view. The outside view is when you estimate how long it will take to write a book. For example, people will often start of writing or chapters in a book. People will actually just kind of add up how long it will take to write chapters and they start with the inside view and say, oh, it'll take about a year, you get all the chapters together. But they don't start with the outside view, which is, when you try to write a book and get chapters, it takes a lot longer, and the average is about 4 times longer than it takes. And I can speak to that right now, as I'm one of the last individuals to submit my chapter in a book that I know the editors are trying to write. So that's the difference of inside view and the outside view. And then you take the inside view, consider patient-specific factors, signs, symptoms, attitudes, adjust the prognosis up or down, and you tailor that to focus on the outcomes that are most important to the patients. Tetlock says, be a dragonfly and seek out the opinions of others. They're good belief updaters. They update the prognosis when new information is available. And the one thing it is be oddly specific about the numbers. The more precise people were, actually, they're actually more accurate, their estimations. So vague descriptors of probabilities, those who were forced themselves to be more specific were better forecasters. And then Superforecasters don't wait for patients and families to ask about their prognosis. They're active. They kind of think, they're aggressive about it. They actually look for competing alternatives. They seek out information that may be different from theirs. They're kind of they're thinkers, not believers, if you will. And this is a cultural change. This dynamic nature of prognosis can help balance the inherent uncertainty, but if physicians are already reluctant to prognosticate one time, it may be difficult to convince many to prognosticate on a more frequent basis. So these is the characteristics of the Superforecaster. They are actively open-minded, and Tetlock even did an actively open-minded scale and looked at actually that kind of open and willingness to seek out alternatives and opinions. And they have dragonfly eyes, the eyes that look in different multiple perspectives. As I mentioned, they're good belief updaters. They're not what he calls hedgehogs, but they're foxes. When the facts change, I change my mind. They use comparison classes and they start with that outside view, and then they go to the inside view. They recognize the legitimacy of competing perspectives and qualify their arguments with buts, althoughs, and howevers. So this is a kind of a conundrum with superforecasters tend to be not as charismatic because they're not big believers. They don't have big ideas. They just are open to all ideas and they update. They translate vague verbiage hunches into precise numeric probabilities. And they do unflinching postmortems on both their failures and their successes. And they recognize that their successes, they may be right but lucky, and their success may be offsetting errors, and they kind of just, they look at it, they try to learn. And if I look back at that patient who I did a terrible job at prognosticating, I was 30 minutes short in their vigil waiting for him to die. I clearly did not tailor my estimate to the individual, 32-year-old male, no history of heart disease, no comorbidities. He was just a young patient who was really healthy. And my experience had been prior to that, doing a lot of brain death examination in the hospital and having patients who had much more comorbidity, much unhealthier hearts, ranging, as I said, from estimates from about a few minutes to up to 18, 19 minutes at that point. And I hadn't had, and I just didn't think through it enough. But I thought about it. And then becoming a so that's a super forecaster. And then becoming a super communicator. I don't say much about this because there's patients and families report a high level of need for information at all stages of disease, including prognosis. While it certainly makes people uneasy, patients and family know it's necessary. And actually, if you share prognostic information, if done well, it does not destroy hope, but can build trust. And we just have to build that courage, that active open-mindedness to talk about difficult realities and co-creating that honest roadmap. There's very little research on this. There was just a study published this past summer, actually last summer, in the Neurocritical Care Journal, just looking at the prognostic approaches of about 15 physicians in intensive care units. And they just classified them as leaving no room for uncertainty, honesty about uncertainty, and kind of providing a range of possibilities. So we know those are variations, and patients on the receiving end or surrogates on the receiving end receive information very differently because attendings and providers change so much. It's often inconsistent. And what they're trying to grapple with in terms of prognosis and what their needs are. I only put this up because this is just one of many protocols that we all know in palliative care. We're kind of the acronyms we use and the words and phrases that we kind of collect to help us through these tough conversations. This is just the one that many of you know, the SPIKES protocol to deliver difficult news. And actually using, and here I just put up the spikes. The K is the knowledge, the imparting of knowledge. So right in that is actually the imparting of prognostic information and some of the ways to actually try to be honest about uncertainty and try to provide a range of possibilities. I worry that, sometimes the language we use just covers such a broad spectrum on the probability scale that, usually from 20 to 80, like the term distinct possibility, that is just tailor-made for that 20 to 80 spectrum range and kind of protects you from over and under prognosticating. But does that really help families? I don't know. And these are just the kind of the ways we have teach it: caveat, ballpark, exceptions, the kind of the wish, worry, wonder framework, and the best case, worst case, and most likely. And I won't go through any of it, but this is just the one, the caveat, ballpark, exceptions, when one's trying to prognosticate life expectancy in advanced cancer, for example, or advanced ALS, kind of trying to provide that range of uncertainty. And then again, I won't go through all these, but just there are ways to address the barriers of communicating prognosis, including prognostic uncertainty, the lack of training, the fear of destroying hope, and not enough time. And I think we as a healthcare system need to continually stress this more and more as I think the Value and Death Commission reports to try to create those new death systems that actually allow for more common conversations about death and dying. And so these are a couple of the ethical questions I have. Most people have only 3 notches in their probability meter in their heads. What obligations do we have to our patients and families to be super forecasters? How good is good enough? And the other is many qualities of super forecaster are at odds with how we are taught to communicate prognosis, like using precise numeric probabilities. And how do we reconcile this as we try to actually do the calculations as best we can, and then impart that knowledge to our patients and families so we can help them make decisions. And then developing radical awareness for common biases that may interfere with your prognostic communication. As I said, that last on the super forecasting was de-bias. What are some of the couple biases that exist? And this is just one quote: providers can be well-intentioned, honorable, dedicated, and have no idea biases affecting care can have devastating effects on healthcare. I'll just mention these briefly: optimism bias, affective forecasting or focalism, self-fulfilling prophecy, and obviously all the other biases associated with racism and other forms of inequity that exist in our society. We know that optimism bias is tenacious. It's tenacious in ourselves, and it's tenacious in our patients and families. It's been known for over 20 years, and it's been shown to be durable and almost unteachable, meaning you can't educate it away. Even after you educate people, they still have it. This is just physicians are overestimators in advanced cancer. The patients and families are even more overestimators. It has what's called a horizon effect. The closer to death, the more accurate we are. Makes sense. And that's also a relationship duration effect, which makes sense. The more stronger, longer relationship you have with someone, actually, the more you probably are biased in the optimistic direction with them. And then the other, so optimism bias of something that I'll speak to at the end in a few minutes. And how well do physicians predict? Oh, and do you imagine the unimaginable? This is affective forecasting. We all know we are terrible at predicting how we will feel in the future, kind of always overestimating the impact of a positive or negative outcome will have on us. So our current selves mispredict our future selves. This is shown in the disability paradox when actually patients rate their quality of life far better than non-patients do. And as we said, some actually even predict it to be worse than death, but those who actually live in those health states rate their quality of life much better. And in fact, there was a study entitled The Happy Majority, Sad Minority, which surveyed patients who are locked in. And the title of it was Happy Majority, Sad Minority, because the majority of patients, even in the locked in state, as Jean Barber would say, who wrote The Diving Bell and the Butterfly, that you can find joy and meaning in that state, whereas it's hard to imagine it when you're not in it. And so this is the affective forecasting. And one of the explanations for why it happens is we tend to focus on the disability, that the colostomy bag, not the 1,000 or billion other reasons where one can find joy and meaning in life, or being locked in, for example, focusing on being locked in and not the ways in which you could still find joy and meaning. And that's the self-fulfilling. I only raise this because I've struggled with this for decades, because it's such an issue in the neurological literature that this is fear of our expectations that someone might have a poor prognosis that may change the actions in ways patients take care of them, leading to the actual self-fulfilling prophecy of a poor prognosis, including death. It's always talked about. I actually continue to wrestle with the ethical issues around it and how do we minimize it. Love someone's thoughts on that. And I just don't know. People just think it's much more of a problem than I do. I don't know how to reconcile this, or I'm still thinking about it. And so this is the classic Muller liar illusion. We've all seen it. And the only reason I mention this is because there are some psychologists who actually believe that cognitive biases are as tenacious as this perceptual illusion. I mean, you can look at this a million times And you can just think that there's two separate lengths. You can put the ruler up there, you can measure it and say, oh my God, they're the same length, take the ruler away, and then you see it again. There are some psychologists that think that some of those illusions or some of those cognitive biases are as tenacious as this illusion. But Tellock and I think that you can actually train in some, and actually he found in his super forecasting tournament that he can train and improve the performance of super forecastings about 10% with very minimal training of awareness. But there are some that are tenacious, like optimism bias. Even after you educate, you can't train it away. And then there are some, not within ourselves, but with our patients, that I think that need to be managed. We have to recognize them, embrace them, and figure out ways actually to best manage them. So it's a very kind of complex process. And there are ways to minimize each. I think this should be more training across all of these, but there's many others. And so the ethical questions here is, how do we have an obligation to inform surrogate decision makers about adapting to new health states, and that our judgments about possible futures are prone to bias? As I mentioned, the happy majority, miserable minority. Most of our guidelines are kind of mute on this topic. And then we know that the expectations of teachers and coaches can influence the performance of their students. Are self-fulfilling prophecies and end-of-life decision-making problematic? How do we know when they are, and why or why not? And then finally, I'll just conclude by a study that was published this past fall on prognostic discordance with colleagues, mostly from Seattle, and my longstanding relationship with Claire Kreutzfeld and her growing research program in neuropalliative care out there. This study is now over 12 years old. I refer to it often. What percentage of surrogates rely exclusively on physicians' estimates of prognosis? I suspect that most of you know, not many. This is less than 2% of surrogates relied exclusively on physician information. I suspect it's even lower than that now, as there's increasing mistrust in the healthcare system and more reliance on the web and information outside of the physician themselves. And they have these other factors. So our surrogates rely on many other things when they form their own opinions. And so this was the study, assessment discordance between physicians and family members regarding prognosis in patients with severe acute brain injury. And we looked at about 200 patients who came into the hospital, and by day, and who had severe acute brain injury, cross stroke, hypoxic ischemic encephalopathy, traumatic brain injury, who had Glasgow Coma Scale, so moderate to severe injury of 12 or below. And on after day 3, we asked a couple questions about what patients or what family members and what physicians thought about the prognosis. These are just quotes from those family members. And so prognostic discordance is when clinicians and patients' family differ in their perspectives on prognosis. In the clinical care literature, rates of prognostic discordance range from over 50 to 61%, the highest being in patients with severe acute brain injury. And if you can think about that discord, that disagreement, it can be due to a true misunderstanding or belief differences or both. And knowledge about that type of discordance can help inform how to address. So I just put these questions up. So these 200 or so patients with severe acute brain injury came into the hospital. They have severe acute brain injury. On day 3, either the family member or the physician were asked this question. I just want you to focus on these two similar questions. What do you think your loved one's chances of recovering to the point of independence or better at 6 months? That's the blue, that's the family member. And what do you think the patient's chances is of recovering to the point of the physicians? And what was the difference that the family and the physician had? And so this was the difference. The difference was on average 33, the physician said 33% chance of achieving independence, and then families said 54%. Now that's the average. And if you take the definition of prognostic disorders in this country was a difference of 20% or greater, actually 61% of the kind of patient or surrogate physician pairs actually had prognostic discordance. So their difference was 20% or more. Now, if you ask the question in red, so we also asked the family members this red question, if you had to guess, what do you think the doctor thinks your loved one's chances of recovering to independence? So that's why we also asked the family member that question. And this is what the family estimate of the physician prognosis was. It actually was 42% on average. So right in between the physician estimate and the family estimate. And then the research group kind of classified this misunderstanding between the physician estimate and what the family said the physician would be. So that was misunderstanding of 20% or more. And then there was also optimistic belief differences, that the family just decided to put down a number that was higher what they thought the physician was. So they just kind of just explicitly said, I think it's better than what the physician. So these two can be defined, misunderstanding and optimistic belief differences, as I mentioned before. And actually a recent systematic review was just published in February of this past year, just a couple months ago, in the Journal of Pain and Symptom Management, looking at interventions to improve prognostic understanding, and identified 12 studies. They conclude that you can do it a little bit, but even after the education, whether it's a decision aid, whether it's a palliative care consultation, whether it's a nurse navigator, actually patients and family members still maintain their optimism up to 90%, up to 90% of them still maintain their optimism even after education. So as I said before, this is just a tenacious bias that we've got to learn to accept, work with, and recognize the value of those hopes and how to handle that. Now, the other thing that we did was we looked at prognostic discordance was greater when family members were in minoritized racial groups. We know that the trust and other factors are, and this has been shown in other studies. And we also found that family members, prognostic discordance was greater when the family member identity as a sibling and adult children compared to spouses. And I think that speaks to my own experience. The spouses obviously just have more intuition about the underlying diseases and the will maybe to live, or that kind of that factor. And then the other very fascinating fact, if you go back to these questions, we also asked the physicians and the nurses, how would you rate the quality of the family's understanding of prognosis for both the physicians and the nurses? And interestingly, nurse perception of fair or worse family understanding was associated with family understanding. So nurses got it. The physicians didn't. The physician perception of fair or worse family understanding was not associated with family misunderstanding, but for optimistic belief differences. So physicians misinterpreted in the misunderstanding with kind of optimism, and that's a bad conflation, because you're not, you lose opportunities to connect with patients. If that's, now this is one study, one ICU, rotating physicians, but I think there's something there. So the ethical questions here: is tenacious optimism bias compatible with informed decision-making? How do physicians best manage a diverse portfolio of hopes? And a wonderful JAMA viewpoint kind of last fall that actually spoke to managing diverse hopes. And then the other is, nurses are better predictors of family misunderstanding than physicians who conflate misunderstanding with optimism belief difference. How can we better train physicians and utilize other members of the care team in the process of shared decision-making? So a couple key takeaways: becoming a master clinician or prognostician requires both being a superforecaster and a supercommunicator whose skills are often at odds with each other. Prognosticating is subject to many biases, which can dramatically affect care. You have to be thoughtful about biases in yourselves, as well as biases in the patients and surrogates you're taking care of. Knows how you can minimize them, know which ones are non-minimizable, and actually those that are probably protective. Patients and surrogates often do not hear what you tell them, and even when they hear you correctly, they inform their own opinions. And prognosticating is of paramount importance to person-centered care, is in need, dire need of ethical scholarship to achieve its ideal. So I will just end there by obviously you got to have a quote. You got to have a quote in there by the Yogi Berra quote. And then the future is already here. It's just not very evenly distributed, which I think the past 2 years have shown us all too much. So I will stop there and have some time for questions.
Thank you so much. That was fascinating and a good reminder of many things, and then a lot of new information that's really worth reflecting on. I see that Joe put a question in the chat, and maybe Joe, do you want to unmute and ask it?
Oh yeah, thanks, Mary Catherine. Thank you, Dr. Holloway, for the really interesting talk. Yeah, I was just curious in that last study, discordance study, whether you looked also at actual recovery rates of patients to see whether that aligned with physician prognosis and the like.
Yeah, in the process of writing that up now. And Claire, okay. I don't know if Claire or others are actually probably aren't on the call, okay. But it's being written up now.
Oh, great. If I could actually ask one other, if it's okay, Mary Catherine, one other quick question. Sort of curious and connecting the dots to where you started with the Lancet Commission study and the global context a little bit, wondering if the biases carry across similarly in different cultural contexts, or whether there are any differences that have been observed there in terms of both patient, family, and clinician biases.
Yeah, I think the answer is yes. I think some of these biases I think run deep and are cross-cultural. This is where you need to bring in, Nicholas Christakis, or the social anthropologist who thinks about blueprints and the origins of a good society and some of the biases we have that can be protective and destructive at the same time, like in-group biases and out-group biases and all those kinds of things. And what are the ways we think to maintain that stability and order in our lives? And I think there's such a drive for that, maintaining stability and not having cognitive dissonance. It's kind of like Danny Kahneman's system 1, system 2. We just do so much to want stability in our thinking, and it's disruptive and difficult to think about hard stuff. I mean, I think it's that simple, but I don't know. So I think the answer is yes, but I'm not the expert there. So
thank you
for that. And then there's a question about the Discord study. Is there data regarding the veracity, length of? No, another great question. I do not believe that question was asked. And recall this study was a study in the intensive care unit. So these physician relationships were probably short but impactful, and didn't have that long-standing opportunity to have a relationship with them.
That makes sense. I have a question too about that last study that you showed, because it was so interesting. And this issue, I definitely can understand the desire for families to have hope, and that explains some of the difference between their perspectives on prognosis and the families themselves. I guess when you said that sometimes families are paying attention, like the quotes that you gave, like, he's young and strong, and so we expect him to do better, or, we're taking really good care of him, or he looks good. I do sometimes wonder, do we discount the wisdom of patients and families with respect to these things too easily? And I know that people are overly optimistic, and so I'm not saying that that we should think that their assessment of prognosis is more accurate than the physicians, but probably everyone's is a little bit inaccurate. And maybe patients and families are looking at things that we don't see because we're not with people all the time. So I wonder if you have thoughts about that.
I couldn't agree with you more. I think a Superforecaster would say you need to consider all the views, and actually so I think Titlock would agree that there's information to be gained by appreciating, acknowledging, and incorporating what we don't appreciate that they do. So I think we definitely have to acknowledge and utilize them in the way we communicate. So, and I think that's the skill of actually, how do you manage? I mean, that's the skill of palliative care, is how do you manage those, it's what it is. It's just it's a hope in a situation where people don't want to find themselves. And so, yes, so it's the point is, I think what I've learned is actually the good person who thinks about prognosis will consider all individuals, and that's what you have to do. So the fact that physicians could think of themselves as not having to incorporate is also a bit, that's kind of a hierarchical attitude that I think is problematic, actually.
Yeah, it's so true. Okay, I actually did miss, there is a question in the Q&A, not in the chat, but in the Q&A. What prognostication tools in neurocritical care are being systematically, with prognostication tools in neurocritical care being systematically flawed by not having taken into account whilst during their development, how do we approach prognostication and goals of care discussions in the neuro ICU?
Yeah, so great question. Obviously, one of the biases with existing data, including existing mortality estimates for patients with stroke and other severe brain injury, is they include withdrawal of care. So there is a withdrawal of treatment. I don't want to say withdrawal of care, withdrawal of treatment bias. And we actually looked at this. The magnitude of the withdrawal of treatment bias is as much as 40 to 50%. And it could probably be higher in some. And so the question is spot on. You always need to think about what would be the mortality or the prognosis in patients who have decided to continue full care and not utilize. So here, using the comparison class or that external view may be problematic. You just got to understand what you're looking at. And there are studies that are now looking at estimates of prognosis unencumbered by withdrawal of treatment bias. One in particular is called the ICH MAX study. So maximal care and intracerebral hemorrhage, to have estimates that don't incorporate that withdrawal of life-sustaining treatments embedded in them. So I always say, if you go to the literature and use those estimates, you always got to adjust the mortality estimate downward when you tailor your estimates, so you don't actually have a falsely high estimate, which can lead to a self-fulfilling prophecy if you're using those estimates.
One comment just to make or pose to you, see what you think about. One thing you said in the very beginning that I'd never thought about prognosis in this way was, you said you defined it in some way about what to expect. And I think, we always are so fixated on, can we make a prognosis of how long someone's going to live as like the main prognosis? And like, that's really the prognosis that we talk about most often. But when you said that, I thought, wow, that really is, it's about helping people know what to expect broadly. So yes, it could be about, how long you're going to live, but it could be about a lot of other things too, that have to do with, the quality of your life, or, how your symptoms are going to progress, or, anything that people might need to know. You just expanded my view of what prognosis could be.
Yeah, and we in neurology, we have our illnesses where mortality is and life expectancy is relevant. The majority of them are actually not. They are more, it's more of it's not how long, but how well, or how and how well. And so that dimension needs to be really, thought through and amplified. And that's where you have some of the other biases. You have the affective forecasting biases where, we gotta just think about how we communicate, and we ourselves think about how well life will be in the future with different conditions.
Well, it is 1 o'clock, and I'm very grateful to you for your fantastic presentation. We learned a lot. Thank you very much.